right, I guess I'll jump right in. I'm Alice. Why are you laughing? Alice, I'm one of the PGY3s. I'm a little under the weather today, so what? Oh, I don't touch it. Okay. I'm a little under the weather, so that's why I'm touching stuff. I can't think straight. But I'll try to go through this quickly for the sake of time. So I'm talking about diving injuries, a little overview about recompression therapy and adjuncts. Okay. So first, special thanks to the Small Talks team for the feedback. I'll do a brief overview of types of diving injuries before jumping into the treatments. So there are two main types of diving injuries. The first type is barotrauma, which can happen during descent or ascent, and then decompression injuries happen only during ascent. So barotrauma basically has to do with the partial pressure or the volume of gases as pressure changes. So here you can see as pressure increases, the volume decreases. So when you're going down, the volume of air gets much smaller and can basically create like small vacuums in parts of your body. And that vacuum can cause like capillaries to burst, which can cause mucosal swelling. This is a picture of mask injury. It's just from like basically a vacuum forming around the mask, which can put pressure on the capillaries. But treatment is usually supportive care. You can also get like neurologic, like inner ear effects from the mask. So if there are like hearing deficits, you can bring in ENT, but usually these are pretty minor. And then barotrauma of ascent happens as the gas expands in the alveoli. So as pressure decreases, the volume of the air goes back up. And so if the gas expands in the alveoli, it can cause like four main injury patterns, which are kind of like complications or progressions of the one before it. So the first is alveolar hemorrhage. The gas expands in the alveoli and just causes damage there. It can cause an intraparenchymal damage. Here's a chest x-ray that shows it. The treatment is usually supportive care, oxygen therapy if they need it. They could have some chest pain, some shortness of breath. The next is pneumomediastinum. So the same injury happens and then the gas travels to the mediastinum, but most cases of pneumomediastinum are also supportive care. If the gas travels to the pleura, it can cause pneumothorax, which you can see here. Most cases of pneumothorax and diving injuries are pretty small. So again, it's supportive care, but if it were a more severe pneumothorax, you could treat it with like needle decompression or chest tube as needed or pigtail as needed. And then finally is arterial gas embolism, which is the most severe of this injury pattern, where gas travels from the alveoli into the capillaries, into the arterial system, and can cause bubbles, which prevent blood flow into the tissues like the brain and cause ischemia or infarct. When it does this, it can cause, like I said, in the brain, neurological deficits, autonomic dysregulation, heart strain, cardiac arrest, same as other clots. Obviously, this is severe, so the treatment for this is hyperbaric chamber for recompression, which I'll get into. This is what it looks like, and it allows pressure, it increases the pressure again to allow the volume to go down, to allow it to go back into the bloodstream. So it's undoing the cause of the gas embolism. Decompression sickness is the other type of diving injury that we see. This is more about like the solubility of gases under pressure. So as you come up and the pressure decreases, the solubility decreases too, and basically all the gas wants to leave your blood system and go into the tissue. And these are like a lot of these are inert gases like nitrogen, for example. It can cause cutaneous decompression sickness, which is pretty mild, just the skin bends. You can see a rash, like a mottled rash like this, or itching or pain around the skin. Musculoskeletal DCS is the bend, so the gas goes into the muscles and causes muscle aches or pains. Inner ear DCS can cause like vertigo, hearing loss. Pulmonary DCS can cause shortness of breath, chest pain, cough, pulmonary symptoms. And then neurological DCS can happen like in the spinal cord or the brain, and this can cause paresthesias, paralysis, back pain. But some of these symptoms can be permanent and irreversible if not treated. So again, the treatment is recompression therapy, which again increases the pressure again, and then allows those gases to go back into the bloodstream, and then they can be slowly released. Recompression or hyperbaric therapy is considered like the standard of treatment in diving injuries. But it's actually not super, super well studied. So when you do recompression therapy, they used to do it with like just regular air and then would increase the pressure. And then more recently, it seems like they're doing usually 100% oxygen or different amounts of gases. And then there's different times that you could be pressurized, like for durations of time, and different number of decompression sessions that you can go into. So none of it has been studied, as far as I could find, very well in like a controlled setting, but it's been happening for so long with diving injuries, and it kind of follows like physical principles, which is why we continue to use it. We don't have them here, of course, at Kings County, but we have hyperbarics available at Jacobi Medical Center in the Bronx, which is pretty far if you're not familiar with New York City geography. There's also a center at Nassau University Medical Center in Long Island, which is 28 miles away, which is also pretty far. In traffic, it could be like 2 hours easily. Okay. So here's a case, a 33-year-old female with no known medical problems comes to the Kings County ED after going diving in the Prospect Park Sea. She was exhaling like she was told to. She's a pretty experienced diver, but while coming up, she developed right lower leg weakness, tingling, lower back pain, and muscle aches in her upper extremities. What do you guys want to know? It's beautiful. It's really deep. It's super deep. Her vital, yeah. Her vital signs are normal. And her physical exam, her eyes look okay. There's no conjunctival injection. Her neck is supple. Her heart is normal. Her lungs are clear. Her belly is soft and non-tender. She does have some modeling on the skin on her back. And her neuro exam, you notice some 2 out of 5 strength in her right lower extremity. She's able to feel your touching, but she says that it feels tingly. But the rest of her extremities are normal. What do you want to do for her here at Kings County with your diver from Prospect Park Sea? Probably not going to be a good outcome for her. What's the treatment? Send her to, yeah. So you call Jacobi, they accept the patient, they're gonna get her there. But it's like a Tuesday at 4 p.m. It's like 2 hours of traffic. Is there anything else that you can do? Oh, helipads, by the way. Putting on not that far. You think about put it in perspective. I mean, that was a question. Okay, good to know. Good to know. So you actually get the helicopter to come, and they're gonna get there pretty quickly. But you're a doctor too, and you want to do something. So is there anything else that you can do while they're here at Kings County? Yeah, so you can get a chest X-ray, you can do these things, but they shouldn't hold you up, right? Because recompression therapy is gonna, like, you don't want to delay it any more than you have to. There's some like adjuncts that have been explored. Again, a lot of this isn't super well studied, so there's not a ton of evidence around it, but if you go to like other places that have lots of divers, we'll see a lot more diving injuries, and they all seem to have their own way of approaching this. Colin told me that his wife was in Malta and went diving and had a had blood from her ears, and it seemed like the diving doctors there just like dealt with this all the time. So we don't see much of it despite our proximity to Prospect Park C. But some people do. So one proposed adjunctive therapy that you can start is an NSAID, which would in theory reduce like cerebral edema and inflammation. Tanoxicam is one that was studied. They basically gave 20 milligrams of tanoxicam during recompression therapy versus not giving it at all. And in this study, there was no difference in outcomes that was statistically significant, but they did have a reduced number of needs of recompression cycles. So there's possible benefit there that may be studied more. Another adjunctive therapy that's pretty commonly accepted, it seems, is high pressure oxygen, so like 100% FiO2, or you could use the Heliox. In theory, this drives other inert gases like nitrogen out of the bloodstream, and it also increases oxygen delivery back into the tissues that are a little bit like ischemic because they're not getting the proper blood flow. One use of this that is like actually pretty, I don't know if it's evidence driven, but it is widely accepted, is for hearing loss from inner ear DCS. They show, or like the articles that I found says that it reduces permanent hearing loss by like maybe 40%. But I didn't see any like RCTs or meta-analyses that supported this, but it is recommended a lot in the sources that I found. And so you want to start 100% oxygen while waiting for hyperbaric therapy to reduce permanent hearing loss. And then the last one here is corticosteroids, which again theorized to minimize edema. It's not routinely recommended. I found this in like a really old US Navy, like this is where I found it, that's the source. So there wasn't much to say about it, but it could be helpful. Another proposed therapy is just like IV fluids, which would again, I guess, try to drive out inert gases and increase like proper oxygen delivery in the blood. But in summary, hyperbaric recompression therapy is the standard for arterial gas embolism and decompression, like severe decompression sickness. I would say that if you have any suspicion clinically that this person is having either of these, or they have a diving injury and they're coming in with any deficits, just try to get them to like a decompression or hyperbaric center immediately. And then adjunctive therapy such as NSAIDs, steroids, and supplemental oxygen have not shown significant improvement in outcomes, but it's probably worth studying, looking into, and probably wouldn't hurt a patient unless they have any like obvious contraindications. And then, like I said, it's been shown, I guess, to reduce hearing loss permanently. So if they have any suspicion for hearing loss, just go ahead and start the 100% oxygen therapy. These are my sources.